If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. Today, we're going to go through the NICE guideline on recent-onset cardiac chest pain, or CG95, always focusing on what is relevant in primary care only. Right, without further ado, let's jump into it. We're going to start by looking at the assessment and diagnosis of recent acute chest pain suspected to be acute coronary syndrome. The term acute coronary syndrome covers a range of conditions including unstable angina, ST segment elevation myocardial infarction or STEMI, and non-ST segment elevation myocardial infarction or non-STEMI. We will not cover the management of these conditions given that this would be done in the secondary care setting. The first obvious thing to check is whether the patient has chest pain at the time of the consultation. If the patient is pain-free, we will check when the last episode was, particularly if they had pain in the last 12 hours. We will see the importance of this and the impact on the possible management later. In order to decide whether the chest pain is cardiac, we will consider the history, the presence of cardiovascular risk factors, a history of ischemic heart disease, and any previous treatment and investigations for chest pain. Symptoms suggestive of acute coronary syndrome are pain in the chest and/or, for example, arms, back, or jaw, lasting for longer than 15 minutes, chest pain associated with nausea and vomiting, marked sweating, breathlessness, or particularly a combination of these, chest pain associated with hemodynamic instability, and new-onset chest pain or abrupt deterioration in previously stable angina, with frequent and recurrent chest pain on little or no exertion, and with episodes often lasting longer than 15 minutes. This will be unstable angina. But we will bear in mind that not all people with acute coronary syndrome present with central chest pain as the predominant feature, and that we should not use response to GTN to make a diagnosis of acute coronary syndrome. If we suspect acute coronary syndrome, we will refer them to hospital, but NICE makes different recommendations as to who we should send to the emergency department and who we should send for urgent same-day hospital assessment. So, if we suspect acute coronary syndrome, we will send the patient as an emergency to the emergency department if they currently have chest pain, or they're currently pain-free but had chest pains in the last 12 hours and an ECG is abnormal or not available. Otherwise, in the absence of clinical concerns, we will refer for urgent same-day hospital assessment if they had chest pain in the last 12 hours but are now pain-free with a normal ECG, or the last episode of pain was 12 to 72 hours ago. We will also refer people for a hospital assessment if the pain has resolved and there are signs of complications such as pulmonary edema. But for this group of patients, we will use clinical judgment to decide whether referral should be as an emergency or for urgent same-day assessment. Right, so that is fairly clear. We will be referring straight away patients who have had cardiac chest pains in the last 72 hours, regardless of ECG, or whether they have complications. But what do we do if we see someone who had cardiac chest pains more than 72 hours ago and who have no complications such as pulmonary edema? Well, NICE says that we should carry out a clinical assessment, confirm the diagnosis with an ECG and blood troponin level, and take into account the length of time since the suspected event when interpreting the troponin level, using clinical judgment to decide whether referral is necessary and how urgent this should be. And this is where it can get a little controversial. Should we be doing troponin levels in primary care, bearing in mind that the results may not be available the same day? If we're worried enough about acute coronary syndrome to be doing troponin levels, should we be asking our hospital colleagues to assess the patient anyway? What would be the medical legal implications in primary care if the patient had a serious cardiovascular event in the intervening period? And all this not to speak that many primary care organizations do not allow or recommend troponin testing in a primary care setting anyway. As NICE says, it always comes back to us. They say that we should use our clinical judgment to decide whether referral is necessary and how urgent this should be. So it will depend on the presentation and our assessment of the risk. And it may very well be that you take the view that most, if not all, of your patients should have their troponin levels checked in hospital. Is there anything else that we should do before referring them to hospital? Well, we should take an ECG as soon as possible, as long as this does not delay transfer to hospital, and we will offer immediate treatment. Let's look at the ECG considerations first. ECG changes that make the diagnosis of acute coronary syndrome more likely are ST segment changes, deep T-wave inversion, or a presumed new left bundle branch block, consistent with an acute STEMI. Also, even in the absence of ST segment changes, we will have an increased suspicion of acute coronary syndrome if there are other changes such as Q waves and T-wave changes, but always bear in mind that we should not exclude acute coronary syndrome just because of a normal ECG. And now let's look at the immediate treatment that we should give in a way that is appropriate to the circumstances. So, as soon as we suspect acute coronary syndrome, we should offer pain relief, which may be achieved with either sublingual or buccal GTN. But we will offer intravenous opioids such as morphine, particularly if an acute MI is suspected. We should offer a single loading dose of 300 milligrams of aspirin as soon as possible, unless there is clear evidence that they are allergic to it, and ensuring that we also send to hospital with the patient a written record that has been given. We will not routinely administer oxygen, but we will monitor oxygen saturation, and we will only offer oxygen if oxygen saturation is less than 94%, if the patient is not at risk of hypercapnic respiratory failure, aiming for a saturation of oxygen between 94 and 98%. If the patient has COPD and is at risk of hypercapnic respiratory failure, we will aim for a saturation of oxygen between 88 and 92% until blood gas analysis is available. But we also need to be aware that some pulse oximeters can underestimate or overestimate oxygen saturation levels, especially if it is borderline, and that overestimation has been reported in people with dark skin. If acute coronary syndrome is not suspected, we will consider other causes of chest pain, some of which may be life-threatening, such as a PE, aortic dissection, or pneumonia. In these cases, and until a firm diagnosis is made, we will monitor patients with chest pain, including a review of symptoms and effect of pain relief, pulse and blood pressure, heart rhythm, oxygen saturation, and repeated ECGs. Okay, we have covered so far patients presenting with new onset chest pain. But what should we do for people with suspected stable angina who present with intermittent stable chest pain? Let's have a look at this scenario. We will start the history and examination documenting the age and sex, the characteristics of the pain, including its location, radiation, severity, duration, and frequency, and factors that provoke and relieve the pain, any associated symptoms such as breathlessness, any history of angina, MI, or other cardiovascular disease, any cardiovascular risk factors, and we will exclude other causes of chest pain and examine for non-coronary causes of angina, for example, severe aortic stenosis or cardiomyopathy. The diagnosis of stable angina based on our clinical assessment will depend on how typical of angina the chest pain is. An anginal pain has these main three features. It is constricting in the chest or in the neck, shoulders, jaw, or arms. It is precipitated by physical exertion, and it is relieved by rest or GTN within about 5 minutes. So we will call it typical angina if all three features are present. We will call it atypical angina if there are only two of the three features present. And we will call it non-anginal chest pain if only one or none of the features are present. The factors that make a diagnosis of stable angina more likely are increased age, being male, other cardiovascular disease or coronary artery disease, like for example a previous MI, and cardiovascular risk factors such as smoking, diabetes, hypertension, dyslipidemia, or a family history of premature coronary artery disease. On the other hand, features that make a diagnosis of stable angina unlikely are when the chest pain is continuous or very prolonged, unrelated to activity, brought on by breathing in, and or associated with symptoms such as dizziness, palpitations, tingling, or difficulty swallowing. In these cases, we will consider other causes of chest pain such as gastrointestinal or musculoskeletal pain. But if there are cardiovascular risk factors, we will still manage them appropriately. If we suspect stable angina, we will arrange blood tests to identify conditions which exacerbate angina, such as anemia. We will only consider a chest X-ray if other diagnoses, such as a lung tumor, are suspected. And we will arrange an ECG as soon as possible, even though we will not rule out angina just because the ECG is normal. There are a number of ECG changes which may indicate ischemia or previous infarction. These include pathological Q waves, left bundle branch block, and ST segment and T wave abnormalities, for example, flattening or inversion. If we suspect stable angina, we will consider aspirin until a firm diagnosis is made, but we will not offer additional aspirin if they're already taking it regularly or are allergic to it. We will follow the NICE guideline on stable angina while waiting for the results of investigations, and you can check the corresponding episode on stable angina on this channel. And we will refer to cardiology so that they can be offered the necessary diagnostic testing, such as CT, coronary angiography, or non-invasive functional testing such as myocardial perfusion scintigraphy or stress echocardiography. We have come to the end of this episode. Remember that this is not medical advice and it is only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.